And so, part two of kind of yesterday's talk, I kept promising to talk about the different issues that you can see with liver transplant for PFIC. And I really, I honed it down to kind of the two major, types of PFIC, or two major phenotypes. And so when you talk about the complications after, you have to kind of think about what the disease is going in. And so, PFIC1, or Byler's disease, and is really the kind of penultimate, or kind of the first disease discovered for this. It has very severe cholestasis. It's a systemic disease, and it's important to understand that it's a systemic disease in the way that your body handles bile acids, in the way that your body handles a lot of different substrates. And although pre-transplant, it's manifested by cholestasis, you often can also get pancreatitis associated with it. Patients with PFIC1 also have chronic diarrhea before anything, before transplant, before diversion, and so it is an underlying issue. There's also an underlying issue with nutrition, and most children with PFIC are on the lower end of the growth curve. Actually, in reality, the majority of patients that we see for transplant have failed medical management, have failed conservative management, and are generally relatively severely malnourished. And it's important to kind of realize that a liver transplant is not a small surgery. I don't have to tell you that. We talked about it yesterday. And that you do require a lot of nutrition kind of going in. And so when you look at liver transplant, most of the patients, or a fair number of the patients who are now being transplanted for PFIC1 have had a biliary diversion. And so from a pre-transplant standpoint, the things that lead you to transplant after diversion is chronic liver disease, fibrosis, and the development of portal hypertension. And so children that have a stoma, or have a piece of intestine that's coming out of their abdominal wall, will, with the development of portal hypertension, often develop fluid inside their belly. That's called ascites. And they oftentimes will, at that point, develop peristomal hernias. And so again, stomas, the piece of intestine that you see coming up through the abdominal wall, kind of go through a hole, but there's only, there's small stitches kind of holding them up to the abdominal wall. And the spaces, there's always a space when you make a hole to put the bowel through. Those spaces can get distended. Those spaces can get weak. And you end up with an area of a hernia between the bowel wall and the abdominal wall. And so you can end up with a relatively nuisance peristomal hernia, especially if you have ascites inside the belly, which can leak out. At the same time, the blood vessels that drain this jejunal interposition are connected to the portal vein. And the portal vein goes into the liver, and it drains all of these. And so when you have portal hypertension, you can develop varices at any site where the intestine is exposed. And so the common sites that you see this after diversion for portal hypertensive bleeding is at the stoma itself. Those are a bit of a nuisance, but at least you can see them, and you can control them with a stitch. Varices that are inside this portion of intestine that goes to the bile duct, you can get to with a scope if you needed to. And again, the jejunal piece of bowel is not very long. And then the more the more troubling sites are areas like this, where two pieces of intestine are sewn together. You can develop varices at that site. And that is hard to get to with a scope. Those are areas that can cause significant bleeding. And similar, if you have a gastrocolonic, or a colonic to gallbladder anastomosis, it can bleed from there as well. When you're thinking about transplant, you also have to think about the biliary diversion and the anatomy that you're starting the transplant with. And so you can actually use this portion of intestine at the time of transplant if it's long enough. There's no reason to waste bowel. You can use that to hook up the bile duct with the roux limb, which we've seen before, and I'll show it to you in a little bit. The other thing on kind of the medical side of this, by kind of nature of their disease, children with FIC1 are nutritionally behind, and they often have a dramatic decompensation in that. They often get much sicker and much punier, to use a typical pediatrician word. It's that children become very puny. They become they have fat malabsorption, they have ascites, they have muscle wasting, they become very frail. And that is much more common in patients with PFIC-related end-stage, PFIC1 related end-stage liver disease. And so oftentimes children require supplemental feeds, whether it's by nasogastric tube or G-tube or hyperalimentation, where you give them food by vein. Because the children have issues with fat malabsorption, you oftentimes need to supplement their hyperalimentation with lipids by vein as well. And so it's important to kind of, when you're starting to think about transplant, when you're starting to think about, am I going to go ahead with transplant, you need to make sure that the child is in the best shape possible. And oftentimes in kids with FIC1, that requires some time on parenteral nutrition. When you think about the post-transplant factors, things that are going to be an issue after transplant, diarrhea is a common issue after liver transplant. It actually oftentimes gets worse after liver transplant initially. And the treatment oftentimes is the same as before. And so you give bile salt binders, you do things like cholestyramine. You can actually slow down the colonic motility with utilization of medications, and so you can actually help that. But it's important to understand that the liver transplant itself doesn't fix any of these other systemic diseases. And so the new liver is making normal bile salts. The enterohepatic circulation, the circulation of bile salts, is actually working better than it ever has in the child's body. And there's all of these bile salts that are ending up in the bowel, and that causes some choleratic diarrhea. It also, early on after transplant, is much more of a problem. And so the children have electrolyte imbalances. The medications that we use to prevent rejection, a lot of times cause issues with kidney short term. And so children oftentimes have some degree of kidney insufficiency early after transplant that you really have to be careful about. And so maybe a child after a biliary diversion who's not on tacrolimus, who's otherwise well, if they get a little bit dehydrated or if they get a little bit acidotic, you say, okay, well, I can manage them with some oral bicarb and increase the amount of fluid that comes into the patient, by mouth. You can't really do that early on after transplant because of the other medications they're on. And so oftentimes children with biliaries would need to be readmitted to the hospital or seen in an outpatient area that you could give intravenous fluid and then have labs checked the next day. And so it's a little bit more of an issue. And again, it's not permanent. It's something that would be, I don't want to say nuisance, but it is something that is it's almost expected in children with FIC1. It's something that you really have to watch out for. And unfortunately, there's not a lot of medical treatment, but again, it seems to get better. The other complicating factor when kids are on immunosuppression, the immunosuppressive medications have to be absorbed, and they're absorbed all through the bowel. Kids that have severe diarrhea oftentimes have issues with fluctuation in the medication levels. And so it's another reason why sometimes you have a hard time early after transplant adjusting those medications in the face of the diarrhea. And again, the management is really similar to pre. You can do bile salt binders, you can do anti-motility agents, and you just have to be very careful about replacing electrolytes. Again, 3 to 6 months after transplant, this tends to be much better tolerated. And we'll talk a little bit about this in a few minutes, but I don't know, nobody really knows the effect of a post-transplant diversion, or even, I dare say, an IBAT inhibitor on this process of diarrhea, or this issue of diarrhea after transplant. What about weight gain? There's actually a couple of good studies that demonstrate good weight gain in children with PFIC after liver transplant. They come into the transplant very small for age. They have moderate, at least, malnutrition prior to the transplant, but catch-up growth really does occur despite the diarrhea. And oftentimes children, because they come in to the transplant without great nutrition, oftentimes post-transplant, and I would say to this, any family that's kind of going toward transplant for PFIC1, I would expect feeds, tube feeds after transplant in an effort to kind of help, and even a short-term period of TPN or hyperalimentation after the transplant, just to allow to kind of account for the metabolic stress of a transplant. I tell people this all the time, that after you have a major surgery, your body, albeit when they put us together very smart. It's not perfect, and so if you've ever had anybody that has had major surgery and you put your hand on their body early after the transplant, their skin is boiling hot, and the reason that is that they've become very catabolic, which means for some reason, and it's in response to stress. I shouldn't say for some reason, it's pretty well understood why. In response to stress, your body breaks down protein, your body goes into a very hypermetabolic state. Anybody that's had major surgery will appreciate, especially if they're old like me, you'll appreciate that you lose weight after surgery. And one of the reasons you lose weight is that your metabolism is 5 times normal, after a major surgery. Unfortunately for kids with PFIC1, it's the same. And the amount of calories that you need after transplant, is 2 to 3 times normal. And to do that with just eating oftentimes is impossible. And so again, I would just, stress the idea that post-transplant hyperalimentation, tube feeds is more expected in children with PFIC1 than other diseases. Fat-soluble vitamin deficiency. So kids with PFIC1 will remain on ADEC, well after transplant. It's well documented. I would expect that as kind of one of the medications that the children would be, mostly because they're so behind to start, regardless of how much you've given. Pancreatitis. Transplant obviously does not change the pancreas, and so the cells inside the pancreas, you still have episodes of pancreatitis. And our longest survivor after a liver transplant for Byler's, we'll talk about that, has actually had episodes of pancreatitis that has been troubling. Kids and adults can get very ill from pancreatitis, and again, the episodes are not it's not a constant problem, but most patients will have an episode of pancreatitis in their lifetime.